Good afternoon, and thank you for joining us today to discuss Certificate of Need laws. I just want to quickly introduce myself. My name is Christina Herron, and Government Relations Manager of Health Policy at the Heartland Institute. Today, we have a great panel of experts in their field. You should have access to their bios, which has their recent and relevant work attached down in the chat room. So feel free to access that. And I want to thank FreedomWorks and Institute for Justice for partnering with us to make this panel happen. And I'm going to pass it over to our panel and let them introduce themselves. And Annemarie, if we could start with you, that'd be great.
Well, hi, I'm very pleased to be here. My name is Annemarie Schieber. I'm the managing editor of Healthcare News, which is a publication of the Heartland Institute and the Goodman Institute. It is the only, I believe, only newspaper that presents the free market perspective on healthcare policy, and it's sent to every elected official in the nation, state and federal, both parties. And we send it out every month, and we've been doing that for many years. So I also work as a research fellow. Before that, I did quite a bit of work working as an investigative analyst here in my home state, Michigan, at the Mackinac Center. And I did mostly video documentary production work. I produced over 140 videos trying to give the real people perspective to public policy problems. And we found that it was a very effective tool in just really broadening our reach. I left a very long, storied career in television journalism. I worked all over the country in various stations, mostly doing investigative reporting. And that's where I really got turned on to public policy. And of course, as we all know, the media world has changed dramatically, and I'm really glad to be in this space.
Josh, would you go next and introduce yourself?
Sure. Yeah, my name is Josh Withrow. I'm a senior policy analyst at FreedomWorks, a DC-based grassroots activist group with millions of activist followers around the nation. We're primarily a fiscal policy, not a think tank, but an advocacy organization. And I've been working there with a brief gap since 2011, and healthcare policy has been one of my dominant policies of interest since then.
Great. Well, we're glad to have you on. And then Jamie from Institute for Justice, if you could give a brief introduction too, that'd be great.
Good afternoon. My name's Jamie Kavanaugh. I'm a litigator at the Institute for Justice. The Institute for Justice is primarily a public interest law firm, but also does strategic research, legislative work, and grassroots activism. We work in a lot of different areas: protection of private property rights, First Amendment rights, educational choice, and occupational licensing. But we've been litigating for almost 10 years in the Certificate of Need arena. And right now I have a Certificate of Need case in Kentucky where we're challenging the Certificate of Need laws as they apply specifically to home health agencies. And on top of that, we recently released a report. I and five co-authors, published a report this summer about Certificate of Need laws, and with specifically an emphasis on what states had to do in response to the pandemic. And what we found was that most of them had to suspend or loosen their requirements, their Certificate of Need requirements, in order to give healthcare providers flexibility to respond to the pandemic.
Great. Well, thank you all so much for being here with us today. And I want to start off by talking about the history of con laws and how we got to where we are today. I guess this question is pointed at the group, so any of you can feel free to jump in. But if you can give a brief overview of Certificate of Need laws and the current anti-competitive practices that are in place and impacting healthcare today, if anyone would want to jump on that question.
Certainly speak to sort of the origins and history of con laws, and I'll let the more specific policy-oriented stuff be taken over by you two. So just the 2 to 3 minute history lesson on how we got here. Certificate of Need laws come from the same sort of mentality and train of thought as the Great Society healthcare laws that were passed roughly around the same time. And the first state Certificate of Need law was actually passed in New York State all the way back in 1964. And a sprinkling of states followed. By the mid 70s, you had about 20 states that had implemented these. After Medicare was passed in 1966, and within the first handful of years after that, you immediately started seeing the costs to the federal government being massively higher than had been intended. The certificate of need laws were seen in their supposed intention was to drive down healthcare costs, and so they were seen as an expedient tool to try to rein in the quickly ballooning costs of this federal healthcare program. And so in 1974, the Congress passed a law, the National Health Planning and Resources Development Act, which basically they realized that constitutionally they couldn't mandate that states pass certificate of need laws, but they did the classic Washington thing, which is they attached federal healthcare infrastructure funding to states having a certificate of need law that matched certain criteria. And so within 10 years after the passage of that law, every state except for Louisiana had passed one. And then in 1986, that law was repealed, and immediately you started seeing states drop off, a number of states anyways, drop off part or all of their certificate of need laws to where now we're in the situation where we have about 35 states, plus DC and a couple of territories that have certificate of need laws. And one interesting one to point out is Indiana, which repealed theirs and then passed a new one 2 years ago when their administration switched parties. And so the other thing I would note in terms of sort of why these came about, there were a number of claims as to why they were necessary that, to me, maybe it's easier with the hindsight of decades behind us and a lot of data, that strike me as pretty absurd, which is that certificate of need laws work by establishing a panel to evaluate whether or not capital investments by healthcare providers are necessary. That's the certificate of need. And the idea is that behind it, or how it was sold, is that it was supposed to, one, help provide an adequate supply of healthcare resources by making it subject to government approval whether or not you could build new healthcare resources. It was supposed to ensure rural access to healthcare, which remains a problem. And it was also supposed to reduce redundant building of infrastructure, which it was thought would pass on the costs of these capital investments onto the taxpayers once Medicare came into the picture, but also just to consumers in general by the idea that hospitals would essentially just keep on building new beds and just increasing the amount that they're billing their patients. And what I just leave with to start here is thinking about it. You're making it more difficult and subject to a lengthy and sometimes expensive approval process to do something like build a new clinic or expand a hospital or buy a new imaging scanner, and expecting that that's going to ensure an adequate supply of these procedures and facilities for the populace. It probably shouldn't surprise anybody that it didn't turn out that way.
Yeah, well, thank you so much, Josh. I think you hit so many good key points, and it's just important to note that the intent of con laws was to lower costs, and that just isn't happening, and we're actually seeing higher healthcare costs in the states that do actually have the con laws, the 35 states that you mentioned. So that was great, thank you. And moving on to Jamie, I do just want to note she has an excellent report that she did mention, and that is linked in the chat under her bio, and she did write that with other colleagues, titled Conning the Competition. And this report is a really great document, and it looks at each state by state specifically, and their con laws specifically. And Jamie, can you just tell us what is the biggest takeaway from this report, and how can legislators use this information for change?
So I would say there's two main takeaways from the report. The first is just that when you compare the con programs across states, you see that there's no rhyme or reason to how states are applying their con programs. There's no cohesion here. It's not as if states are all following a formula because con laws actually produce higher quality healthcare or increased access to healthcare or decreased costs or something like that. As Josh just mentioned, con laws aren't accomplishing any of their goals, and actually there's ample academic literature about this. The federal government has disavowed con laws since 1986. consistently, both administrations or, Republican and Democratic administrations have continually disavowed these laws. So instead, what we see is programs that look kind of like have a Swiss cheese effect, where they look the exact opposite in some places, where we have states like Nevada who require a hospital to get a con before opening only in rural areas. This is something Josh just mentioned, that sure, there's still concern about rural areas, but then we see states like Oregon, Washington, Alabama that exempt healthcare facilities from getting cons in rural areas. So they're doing the exact opposite thing, and saying, but still saying that they're accomplishing the same goal. So both of these things can't be true. It can't be true that we need cons to keep facilities in rural areas, and yet we can't have states that exempt rural facilities, and then yet states that keep the cons in place for rural facilities. So instead, what we think this means is that it's just the laws are a result of a lot of lobbying and special interest groups and hospital associations and different organizations that are all in the capitals and arguing for their own self-interest. And I can point out, my own example from my case in Kentucky. My clients are immigrants from Nepal that wanted to open a very small home health agency to cater to the Nepali-speaking community in Louisville. They looked around and they saw the aging population couldn't find home health services from home health aides who spoke Nepali. And so they thought, we can figure out a way to offer this service to the community. And when they filed their application for the certificate of need, a $2 billion healthcare conglomerate came in and opposed their application and said, we're taking care of the area. There's enough home health care services in Louisville, and the state denied their application. On top of that, the state in Kentucky anyway looks at just a blanket formula, kind of this mechanical formula that doesn't take things like language into consideration. And so, that's another reason their application likely would have been denied anyway, even if their direct competitors didn't come in and oppose them. But the system is built so that at every step of the way, an entrepreneur, a new medical provider, it's almost impossible to open a new business. Okay, so I mentioned some examples of how the programs in different states, kind of look the exact opposite. Another example is in New York State to open in New York State to add beds specifically that will treat patients with AIDS at skilled nursing facilities. It's that specific. You need a con for that. And in Connecticut, they exempt that exact service. In Missouri, they go further and they say you can open a whole nursing home without a con. Even though nursing homes normally need a con, you can do it without a con if your facility is going to treat patients with AIDS. So again, you see these really specific carve-outs that create these weird incentives, or kind of box in providers sometimes, and just don't give them the flexibility to provide the services that patients actually need. So that was the main finding from the study. And the second finding was just that in response to COVID, 25 jurisdictions, 24 states plus DC had to suspend or loosen their con requirements. And so obviously that tells us that con programs just aren't allowing healthcare providers the flexibility they need. If con programs were in fact increasing access to healthcare or accomplishing any of their laudable goals, you'd think that we would want more of those during a pandemic, not fewer.
Right. Well, thank you for pointing that out. And it kind of seems like we're coming to the conclusion that con laws are in nature arbitrary and anti-competitive and crony in some manner. And so I think that the COVID-19 example is very important. If the regulations aren't necessary now during COVID, should they be necessary after? And I think that that's happening in lots of different industries. We're seeing these regulatory practices come into question. So I really appreciate that. I was going to ask you about your Kentucky case, but you kind of broke it down for us. But moving to another state, could you mention what's happening in Florida, since you did mention earlier there is a case there as well?
Yeah, that's not an IJ case, but Florida is actually a great example because a year ago, Florida went through a big con reform, and it got rid of most of its, it got rid of most of its con requirements, and then it sunset additional requirements. So it has many con laws on the books now that will sunset next July. So this was a really interesting way for the legislature to go through con repeal. It's really giving all of the providers kind of time, I guess, to adjust to the changing circumstances. I don't know the exact contours of the Florida con case. That's not an IJ case. I can talk about a case in Nebraska that we have where we have another entrepreneur, an immigrant, who opened a home health agency, because in Nebraska you don't need to get a con to open a home health agency, unlike in Kentucky where our clients do need a con to open a home health agency. So he started his home health agency, but he does need a con to provide non-emergency medical transport. So that means transporting his patients to their doctor's appointments or transporting them to the pharmacy to pick up medication. And so he likes to say that he's allowed to drive his patients to Walmart to help them grocery shop as part of the home health services, but he's not allowed to drive them to Walmart to go to the Walmart pharmacy. That's how the regulations in Nebraska apply right now. So we're suing there to challenge that con law. But again, you know, it's his patients who are already comfortable using his service. They have to call and schedule their transportation to doctor's appointments with a totally separate service. They've all had experiences where they've been left waiting at their doctor's office for hours, waiting for this other transportation company to come pick them up. It's these barriers to the services that patients need that are created by con regulations that we see over and over again. And sometimes it's hard. There's a little bit more distance between the barriers created by con regulations and the harms to the patients. It's not as direct as in some other types of regulation. But so finding human interest stories is sometimes a little bit more difficult. But in a lot of these areas, I think the problem is that cons were originally envisioned to regulate expensive things like hospitals. The original idea was that we don't want two hospitals to open around the block from each other and sit half empty. But when we get down to things now like home health or non-emergency medical transport, these are things that don't have a large expenditure, that aren't going to be a drain on capital, or, you know, if a home health agency opens, there aren't really any capital expenditures. In the Kentucky case, we just had this great opinion on just the motion to dismiss stage where the judge said, what is the capital expenditure for opening a home health care? It's just one employee and a tank full of gas in their car. That's it. There's no overhead to open a home health agency.
Right. Well, thank you for sharing that case as well. And yeah, it does seem like there's a huge issue with there's a huge barrier to access that con creates for so many patients. And on that note, I also want to bring up the fact that it's not only barrier to access, but also there's regulatory burdens putting limits on innovation and technological advancements. And Annemarie, I want to direct this question toward you and some of the work and research you've been doing on the regulatory burdens limiting technological advances and medical advancements from cons.
Uh-oh. Looks like we may have lost Annemarie here.
Oh no. Okay, well, I know she has great work on it, so hopefully she'll be able to hop back on and really start talking about the technological advancements there. But moving forward, I have a question for Josh and Jamie while I have you both still on. Can you also, I know you guys talked a little bit about the connection of COVID-19 to con laws and really poking holes in these regulatory policies that have been enacted in the states. Can you give a few more examples, whether it's a lack of bed or not enough ventilators, or even, you know, the number of hospitals that have been available? Can you point to a few examples where COVID, you know, has really poked holes in the con law?
Yeah, certainly. I mean, I'm not remembering off the top of my head the full list, but I think it's 25 states that in part or in full suspended a number of their con provisions in direct response to COVID, and it was for exactly the sort of reasons that you just said, like in New York, where they were worried about hospital capacity and wanted the ability to set up, you know, to expand beds or set up new facilities quickly, and they just had to make the con laws go away in order to allow that to happen in a timely fashion. And that was true for basically major cities all over the country who were worried about bed capacity, which fortunately mostly didn't get tested. But it did show, though, if you're worried about the capacity existing, why was that capacity not there in the first place? Well, one of the reasons why it wasn't there in the first place was probably the existence of these certificates of need.
Yeah, and I'll just add to that, the Mercatus Center at George Mason University has done research that shows non-con states went into the pandemic with more hospitals per capita, with more hospital beds per capita, with more surgery centers per capita, with more dialysis centers per capita. So things like that, you know, they were already better equipped. And then on top of that, they didn't have to make their providers jump through additional hoops and fill out additional paperwork to respond to the pandemic. And so Josh is right, that number is 25 states had to suspend or loosen their con requirements to respond to the pandemic, but included in that number are states that still are making their providers fill out emergency con applications. So unfortunately, you know, they're still creating some hurdles, even though it's a reduced burden, it's not a full-blown con application. They're still forcing providers right now to spend time on paperwork and ask permission to add hospital beds or add ventilators, things that, you know, it kind of seems absurd. The hospital, you know, is adding beds because it wants to be ready to provide the public with these services.
Sure. Yeah, I completely agree and think it's shocking that we're even having this discussion and are in this situation. I also have my last question for you all. Is there any solution or strategies to repealing con laws that you all can think of for state legislators? Is there obviously the lawsuits that the community members you're working with and you know, suing the state or different governors and their capacity? Is there anything else that folks can do to educate people or move forward with repeal?
Well, I would say one thing to start with, and you know, I'll happily flag another organization's work on this, is and just to double down on what Jamie said about the research that the Mercatus Center has done on this. Tom Stratman and Chris Koopman there over the past 5 to 8 years have produced some of the absolute best sort of empirical studies that I've seen anywhere in terms of just documenting these 50 years now of results. Of an economic data that prove pretty conclusively the ways that con laws have actually harmed the cost of and access to healthcare across the nation. And so, you know, armed with these facts, I think it's becoming pretty easy to convince people that con laws are problematic in terms of. And I think the other thing that helps is that people inside the healthcare industry are finally starting, not the hospitals so much because they now have a vested interest in keeping these laws around, but doctors and other you know, stakeholders within the healthcare community are increasingly starting to realize that the market concentration that is being created artificially by laws such as certificates of need, they're not the only law, but certificates of need are a factor in this. Are preventing them from being able to adequately deliver care. It's impacting their ability to help people, which is their job. And so you're starting to see organizations of actual physicians. One that I work with that I'm familiar with is Physicians for Reform. There are others who are speaking up about the need to deregulate and including getting rid of certificate of need laws at the state level. And you know, doctors are a very trusted voice. It's one of those things where we can feed people the economic numbers until you know, all day. But when you start getting medical professionals speaking up and going, guys, this is a problem, that really changes hearts and minds faster than any numbers I can shout at you.
Right. Yeah, that's great.
That's a great point. We have another case in North Carolina where we're representing a doctor who wants to do surgeries, and he actually owns his own surgery center, but the state says you can't use your surgery center without getting a con. You have to go to a hospital to perform these surgeries, and it would be much less expensive for patients if they could use his surgery center, but instead he has to go to the hospital and pay the hospital's surgery fee. And so his patients are paying, $2,000, $3,000 more every time, at least at a minimum more for their surgeries every single time. So there's, all these benefits. Yes, Josh is absolutely right that doctors are becoming aware of the burdens of con, and there's all these benefits to patients as well if we reduced cons. So, you asked about what are the ways, I guess, to move forward with repealing cons. New Hampshire was the last state in 2016 that was able to fully repeal its con program. But if that is something that isn't politically feasible in a state, then there's still other things that can be done. As I mentioned, Florida was able to get rid of a lot of its con requirements without getting rid of all of them. And it included these sunset provisions that gave providers a lot more time to kind of adjust to the new climate. Another thing that states can think about doing if they don't want to get rid of the entire program is to add expenditure minimums so that cons don't kick in until a provider is going to spend a certain amount on a new service or on building a new building. If we make these expenditures really high, like $10 million or $20 million, then most people are going to be able to do what they want to do in the healthcare arena without having to get a con, which is a good thing. The other thing to do is to look at the regulations and ask what kind of application requirements are there, what kind of application fees are there, how active are the applicants' competitors allowed to be. A lot of times the con application process looks like a full-blown civil trial. The direct competitors, like I mentioned in Kentucky, my clients were opposed by a $2 billion healthcare conglomerate that were represented by attorneys, and you go to what looks like a trial. They have exhibits. You go in front of an administrative law judge. You have to be represented by attorneys. It's very expensive, and so if you get rid of some of those requirements, states like Nebraska and Michigan don't allow competitors to be involved in the application process. You at least are decreasing some of the barriers that are imposed on applicants who are trying to get cons.
Right. That's really creative too, to work within the confines of con laws, just making them not applicable to what people are actually doing. That's a smart way to go about it. Annemarie, we're glad to have you back on. I did want to touch on the limiting of technological advancements and medical advancements we're seeing in the industry and how con laws really do impede on those. If you want to touch on some of the work
Sure.
that you guys have been putting out in healthcare news, that'd be great.
I would like to speak a little bit more to why we need to change con as to how.
Sure.
There is a lot about con that we can discuss, and I'd like to focus a little bit on the disbursement of technology and knowledge sharing. So, one of the main premises of con laws has been to restrict market competition so that we could create these centers of excellence. The idea was that if you had too many people offering the same service, no provider would get good at what they were doing. And, that might have been fine in the 70s and 80s when we had many new technologies in healthcare coming on the scene, organ transplants, for example. But, we have come a long way, and look at what we now know about COVID in just a few months that we've been dealing with it. A study came out recently from Mercatus that found mortality rates were higher in states with con laws, and that there was a significant reduction in death, not just in COVID, but other diseases, when these states temporarily restricted their con laws. So more and more evidence is showing that, these are really becoming a problem. Competitive, very quickly changing climate. Information and knowledge spreads rapidly with digital technology. And when we prohibit professionals from gathering information and developing expertise, we could spurn we could block a lot of new innovation. And if we allow people to be able to practice and get more into the healthcare sphere, we can maybe, come up with even more innovation and better ways to develop healthcare. And you can't do that when you have a small panel of people not working in the trenches calling the shots. Everybody loses. And I think the best way to describe what I'm talking about is to share a personal experience. 16 years ago, my husband was told that he had non-Hodgkin's lymphoma, and it was devastating news. He was in the prime of his life. Our children were quite young, and we lived in a great community, except for the fact that we did not live near a cancer center. The doctors told him the only way of a cure would be to get a stem cell transplant, and the closest place offering this procedure was 2 hours away. I won't go into too much depth of what this procedure involves, except to say that at that time, a stem cell transplant was a very risky deal. What they do is they blast away your cells and pump in new ones, either from your own body that are treated or from someone else. In his case, his donor was his brother. We were not in a position of moving. We were both employed in our city, our kids were in school, and so we decided to commute to get this care, and we had no idea what we were getting into. After the transplant, which is a really uneventful thing, it looks like a blood transfusion, you're required to live in the area for a couple of months because you can become lethally sick very quickly. And if you're back home, your local hospital may have no idea what your history is. So we rented an apartment, and for a couple of months, he stayed out there. Various relatives would come in and care for him as a caregiver. Within a month, he got incredibly sick. He got something called graft versus host disease, and he was hospitalized again. Generally, what happens is your stem cells, the new cells, reject the host body. And so to fix this, doctors have to shut down your immune system, which makes you extremely prone to infection. So after a month, he came home for about a week and then came down with something really, really threatening called fungal pneumonia. And that's even more dangerous than graft versus host disease or cancer. It's very difficult to treat. Doctors have to use very toxic drugs to do it. He was in the ICU for about a month. He did get out. And of course, once again, the graft versus host disease came back. To wrap it up, he was in the hospital for 4 entire months in that first year, 2 hours away from our home. And my biggest fear that he would die alone. And I knew somebody that had happened to. And, he never, to make a long story short, he never recovered. He lived 4 more years. Graft versus host just took over his body, eventually attacked his lungs. There were various treatments he could have had, but they were very time intensive. One of them was a really cool thing using UV light. But again, he had to travel to this cancer center 2 hours away several times a week and sit there for hours on end. And I kept wondering, why isn't it? Why do we not have these services in our hometown? And that's when I came to discover con laws. It was the state's con board, a group of appointed people who decided things like which hospitals can do a stem cell transplant. Why were they concentrated in one area of the state? Was it, you had to wonder, was it political? The local hospitals in my neck of the woods were not mom and pops. They were growing. They had a lot of philanthropic support. They were approved for transplants for children. And in fact, like I said, they could not get access to, they did get some treatment in there. But they just were not up to speed in how to do it. He would come home with lots of complications, bruises on his arms and so forth. So they just never really were able to catch up to this other center that had this privilege of being able to do transplants. 15 years later, you would wonder that con laws would be gone, but they're not. They're still here, and they're getting in the way of technology. When the Trump administration announced last year that Medicare would be covering this innovative treatment that could save lives for some blood cancers, it gave patients a lot of hope. It's called CAR T-cell therapy. And, basically they collect patients' T cells and genetically modify them so that when they're reinfused in the patient, that they can latch onto these tumor cells and kill them. Had this treatment been around 15 years ago, perhaps my husband would be alive. because the technology behind the process has already been done, the treatment has been done. CMS has allowed anybody to offer this facility as long as they are enrolled in the FDA's drug safety program. And in my state, the Con Board decided that it was going to impose an additional accreditation recommendation or requirement on top of the CMS guideline. And so what happened was, naturally the dominant cancer centers had this accreditation so competitors could be locked out. Well, Heartland Center learned about this. This was not that long ago, a couple of months ago. And we started writing papers, op-eds. Michigan State Senator Kurt Vanderwall took the lead in this. He objected at the Con hearing. To make a long story short, there was a provision in the law that allowed the state to override this decision. And fortunately, they have been able to block this extra requirement that the Con Board was trying to change. And I think that has also helped propel or motivate lawmakers to realize how serious this is. We have these new technologies coming onto the scene. And, if we're going to block them, we're not going to give places the opportunity to develop the expertise. We're not going to be able to share this technology with a broader range of consumers, and everybody loses. So even more now than ever, it's really important. I think it was Matt Ridley who said that innovation cannot be forced, but it can be quashed. And when we use panels to restrict the organizations that can develop this expertise, we all lose.
Well, thank you so much for sharing that story with us. And, I will make sure to attach some of the work regarding the con laws that Healthcare News has put out under your bio as well when we publish this video. And to the audience, I just want to ask if anybody does have any questions, feel free to type those up in the Q&A below, and I will read those to our members if anyone has questions, or if anyone on our panel has any final words for our audience while they're thinking of some questions.
Christina, can I add just, there's a link that I'd like you to include. It was an interview that I did with 3 lawmakers who were really trying to repeal con in their states, Missouri and Tennessee. And they gave very candid answers, responses to what the obstacles were, where they were facing, who they were up against, the kinds of arguments they heard. I mean, they're still pushing away. COVID changed a lot of it. They were really, spearheading, really going full force on this. And so it might be interesting if anybody's looking to reform to hear the experiences of other lawmakers in other states and what they came up across.
Yeah, that's phenomenal. I'll make sure to attach that as well.
Yeah, one quick thing I would add, just because I am of this group, the DC swamp dweller. There is a federal component to this that I think may bolster some of the arguments against con laws at the state level, which is that there's an increasing amount of focus at the federal level in Congress on this level of market concentration that we're seeing among hospitals that's created by all of these barriers that exist, of which con are only one, to establishing new services and competition. There are some very alarming proposals that are coming about actually, and the worst part is that they're coming around from both parties in terms of how federally they might try to deal with this, with these regional and local hospital monopolies. And instead of knocking down the barriers to why they don't have competitors, they're talking about doing things like antitrust enforcement, which breaking up some of these hospital monopolies might, in the short term, stop their dominance over the markets, but it won't stop their ability to block construction of new facilities through con laws, and also will impose a massive cost. If you want to talk about a service that's going to cause hospitals to divert large amounts of money away from the actual care of patients and towards litigation, and that will in fact increase prices. FTC antitrust cases take years and sometimes even sometimes a decade or more, and impose massive costs. So not only is it not a good free market way to handle the problem, and it kind of ignores the reason why we have this market concentration in the first place, but it will have adverse consequences, at least in the short term, that are going to cause major headaches in the states where these cases are pursued. So I think people should be aware that that is actually a conversation that's being had in some of the halls of Congress that is ominous.
Yeah, that's really important to note, Josh, about the federal angle to this, because I think a lot of federal legislators maybe don't know what to do or don't know that they could be involved in kind of combating this con law situation, because it really is a state focused issue. But there are examples here where federal legislators could in some capacity get involved. And I also want to address this question to the panel. This is from Alyssa Hutchinson. She says, so would you say that con is a bipartisan issue, or does one side tend to defend them more than the other? That's for everyone.
They're worried about getting reelected. And, you know, you're up against some really powerful forces, lawyers. And, you know, the thing is, we don't see how the activity that is, you know, that doesn't come into a state because they're so afraid of going through this process. You know, when investors come in, they're going to do their diligence. They are going to make sure there is a market there. They're probably going to do it much better than a con board can. And, you know, I've heard comments too where hospitals are using these laws to even do their own bargaining. There's some laws there that where con does not apply to expenditures under a certain amount. So they'll go back to a provider and say, get it under this price so we don't have to go through this process. I mean, we shouldn't have governments for, you know, doing the negotiating for providers. You know, that's basically what this comes down to. They're using these laws to promote the market in the interests of very few players. And I don't know, you know, I think you can get, everyone that I've talked to has been on one party, the Republican Party, but I think this is just, this has to, you know, I don't know how you could make this a partisan issue. It's a very pro-consumer idea.
Do y'all have any thoughts? Any other thoughts on that?
I've seen some hesitancy sometimes from Democrats to the idea that if we admit that con laws aren't working, it might be a general admission that central planning for healthcare doesn't work, or, you know, it's an admission that like Medicare for all isn't going to work or something like that. So, you know, to be in line with this general idea that we have to have a united front about centralized government funding for medical services, I think there's less appetite, at least in my limited experience, I think there's less appetite from Democrats for con reform, but that might change in the era of COVID because now we've seen Democratic governors issue orders suspending con programs.
Right.
Agreed, especially at the federal level. That's even more true than in the state houses. Even though the evidence is plainly there to show that the con laws are not achieving a great deal of benefits for patients, they are in some ways a part of sort of a key part of the broader vision among Democratic policies, progressive policy circles towards concentration of the markets. And, you know, like the ACA, when it was passed, one of its primary goals, as written by some of its authors, was to actually increase the concentration in healthcare, because then it would be easier to administer centrally. And so the fact that it is in fact restricting access to care in rural areas is seems to be, at least by their actions, perceived as a unpleasant but necessary side effect of the greater plan, which is to achieve a national health system.
Right.
We know of Republicans who blocked con reform as well. So I don't know that this is a very partisan issue. There's so many special interests involved. We knew of one state where they tried to repeal it because there was a nursing home going up in somebody's backyard. They didn't want it there, so they went to the con board and they tried to change it that way. I mean, that's not what we should be using government laws for, to exercise the special interests of a limited few.
Right. Yeah, and I do just want to comment, if you are a free market, liberty-minded individual, you know, I think that you would definitely be in support of repealing con laws, at least in some capacity, or rolling them back. So you should be, at least. If there aren't any other questions from our attendees, which I haven't gotten any other questions here. Oh, here's one more question. Is there a collaborative way to work with corporations as well to target the issues with big corporations pushing out new providers from opening. So I don't know if this is referring to a private-public partnership. And this is from anonymous attendee, if anyone wants to address that. So the question, I can read it again. It was a little, is there a collaborative way to work with corporations as well to target the issue with big corporations pushing out new providers from opening? So I guess the anti-competitive practices, and it says referring to competitors being able to argue a new one from opening.
So the one thing I can kind of speak to is, so in terms of the hospital associations themselves, I'm not sure that there is, because there's just no benefit to them in doing that unless you can like publicly shame them for their anti-competitive practices to the point where they feel the need to play along. But there is this power dynamic that I see pretty clearly in DC that can sometimes be useful, which is that some of these anti-competitive practices that benefit hospitals and facilities do a great deal of disservice to the doctors, the physicians practicing in them, and also sometimes to the insurance companies in terms of skewing payments. And so there is, in fact, it's kind of icky, but there's definitely it's necessary often to sort of play those dynamics against each other, so that you can have some of these other industries, sort of tattling on the guys who are the bad actors in this case, being like, hey, this is actually hurting patients and isn't the right way to go. So sometimes you can work with the insurers against hospital concentration, sometimes not. It depends on whether their interests align. I haven't explored that dynamic on this particular issue, so I don't have a definite answer, but that's just something that becomes part of the process when you're dealing with policy at the federal level.
Sure.
Oh, go ahead.
Well, I'll just say briefly, another thing is, I think sometimes some of the things hospitals are upset about are really just Medicare reimbursement rates. And so, they try and say cons are necessary to pad our bottom lines, but that's not really what cons are built to do either. So if that's, that is how they're being used a lot of times, but that's what we've just been talking about. That's not right, that the government isn't really creating these laws to keep out competition. And in fact, we have all these negative externalities. So, that's not a reason to keep con laws on the books. And this is something we haven't mentioned today, but so when we say there's only 12 states without any type of con program, that doesn't sound like a ton, but it's actually about 40% of the population of the country lives in a non-con state. This includes states like California, Texas, Pennsylvania, Colorado, but rural states as well, Idaho, the Dakotas. So we really have the full gamut of, red states, blue states, rural states, less rural states, that have functioning healthcare markets, that have hospitals. The hospitals haven't gone out of business. So we really have a lot of data points to push back against hospital associations and other organizations to say that the sky's not going to fall if con laws are rolled back.
One thing we didn't mention that's somewhat related to con is the growing use of non-compete clauses for physicians, as there's a lot of concentration going on in the hospital industry. Now, maybe this has changed with COVID because physicians are really rethinking their practices, but over the years, the trend has been a number of doctors working for large employer groups, hospitals, and then locking them into contracts. And one of the problems is they restrict them from leaving and practicing in a market for long periods of time. And I know states like Indiana and South Carolina are really looking at these clauses and trying to find ways to allow physicians to be able to practice. I mean, they're very prohibitive, and something maybe we need to be on a lookout for.
Yeah, well, thank you for that input. I also just want to give you all on the panel one last shot to give any plug for any cases we should be looking out for, organization, how folks can stay in touch with the work you're doing, or any other final comments you have here to wrap this up.
I'll go ahead and mention that IJ just rolled out a new legislative service where we're working on the ground with legislators at the state level and at the city level. So if you go to 2021initiative.com, you can see the types of services that we're offering there. And it's really to address the myriad crises that have occurred in 2020 and to make sure that 2021 is a year of recovery, but healthcare is a big component of this initiative. And so, of course, repealing con laws is one of our major goals with that initiative. So you can find out more about that at 2021initiative.com.
Great, thank you.
Yeah, I would just say for FreedomWorks' part, I mean, our primary purpose is to be a service center to grassroots trying to create change in their states and at the federal level. But we actually had been in talks and working with both activists and folks in state legislatures on con laws before the COVID happened and everything shut down. And I think there's a momentum here that hasn't been present in years past. I'm back in 2012 and 2013. I tried to look around and see if there was any interest in amending or repealing con laws in the states, and there just wasn't. I had no ability to just even detect any interest to make that happen. Now you're seeing movement and actual real interest in over a dozen states or more. So what I would say to the audience, particularly those of you who are in state legislatures, is if there's any interest in that, definitely do reach out to us. We may be able to help educate grassroots activists and also just the public in general in your states, and to maybe give some extra tools to boost your message and help make that happen. So definitely keep us in the loop. We don't have a dedicated a team of people in every state watching what's going on. We do rely on folks like you guys coming to us to let us know, hey, this is happening and we need help.
Awesome.
I'll put a plug in for healthcare news. We mail it out every month free of charge. And we're really keeping tabs on this. One of the useful things about this publication is that you get names of other lawmakers. I've actually had calls from state lawmakers wanting to get in contact to somebody who they read about in the newspaper so they could figure out, maybe a different strategy in getting some reforms passed. So it's been kind of a good clearinghouse. And if you're not on our mailing list, do please contact us and we'll be happy to add you.
Yeah, that's awesome. And thank you to our panelists for being on here and talking about this really important issue. And to our audience, thank you for hopping on. And if you did miss anything or do come across a question later on, please feel free to reach out to me. We will be posting this on our Heartland YouTube page and on the Heartland website, so you will have access, and I can always relay a question to one of our guest panelists if you do need more access to them to discuss this issue. So thank you all so much, and I hope you have a great weekend.
Thank you, Christina.
All right, bye-bye.